substandard and falsified medical products, and antimicrobial resistance. This session is being hosted by Global AMR Media Alliance, or GAMA as it is more commonly known as. A few quick housekeeping announcements before we begin. Participants, please type in your questions in the chat box as the speakers present. We will take up the questions for our first two speakers right after they present, and the rest of the questions will be taken up later. As we all know, according to the World Health Organization, substandard and falsified medical products affect people all around the world. At least 1 in 10 medicines in low and middle income countries are substandard or falsified. In other words, 1 in 10 people who are taking medicines they believe will help them relieve or cure them are being failed. Substandard and falsified medical products pose significant threats to public health globally. They can be ineffective at treating the illness as they may contain incorrect ingredients or incorrect dosages. They can even be directly harmful to patients if they contain contaminants or toxic substances. They may be indirectly harmful through increased risk of antimicrobial resistance, or AMR as we call it. Today, we will hear from our experts about the problem of AMR as it continues to be among the top 10 global health threats. We will also hear about the challenges substandard and falsified medical products pose and their link with AMR. We will also learn more details about a great British pound 1 million competition of the Trinity Challenge to spur innovations for finding solutions to address the issue in the global south. And best of all, insights from those who are successfully journeying from idea to innovation and to impact. Without any further ado, I invite our first speaker for today, Dr. Kamini Walia, Senior and Distinguished Scientist at Government of India's Indian Council of Medical Research, or ICMR as we call it. Dr. Walia leads AMR initiatives at ICMR and also guides Global AMR Media Alliance as its scientific chairperson. Welcome, ma'am, and over to you.
Thank you, Dr. Shobha, and thanks for inviting me to this very important discussion where we'll be discussing the impact of substandard medicines, counterfeit medicines on the problem of antimicrobial resistance. Can I have my presentation, please? Next, please. So antimicrobial resistance develops when the organism is able to resist the killing effect of antimicrobials. It is not a new phenomena. Ever since antimicrobials were developed, antimicrobial resistance followed the development of new antimicrobials like a shadow. However, lately we are seeing rapid surge in development and spread of antimicrobial resistance, which is assuming public health concern. And there are now estimates which are available to us, which were not available many years back. And from those estimates, we know that almost 5 million deaths are lost to antimicrobial resistance every year, out of which almost 1 million deaths are directly attributed to drug resistance. And this is expected to the number of lives lost as well as the loss to economy is expected to be huge in coming few years. And one of the estimates is that by 2050 the total cost of 100 trillion to global economy may be incurred through the loss of productivity. And besides the drug resistance disrupts our achievement towards sustainable development goals of no poverty, zero hunger, good health and well-being, inequality, as well as economic growth. Next, please. There are various factors which lead to development of resistance. One of them is prolonged antibiotic courses, inadequate or suboptimal doses of antibiotics, and that's what we will be hearing more about in next few talks, where the other speakers will be talking about the impact of suboptimal doses and what is the prevalence of this practice globally. Poor infection control practices, whether it is in the human sector or in the animal sector, are actually compromised by overuse of antimicrobials, which lead to development of drug-resistant mutants. We also know that antibiotic residues in environment or in the livestock and the poultry, because of excessive use of antimicrobials in these two sectors, are also contributes to development of drug-resistant mutants. A lot of antimicrobials are used in the animal production, and the impact of those antimicrobials on emergence of drug-resistant mutants, which subsequently contribute to the human dimension of AMR. Although there is some evidence, still a large-scale evidence needs to be found out. Various pathogens like Salmonella, E. coli, Staph aureus, Campylobacter, they actually make way to human beings through food chain and food products which have animal origin. Next, please. So, antimicrobial resistance is actually threatening the advances that we made collectively towards control of infectious diseases. And this is more so in low and middle income countries, where the economic and the human cost of AMR is huge. The drug resistant pathogens complicate the treatment of infections in community which are acquired in hospitals. For example, now we have a huge burden of hospital acquired infections as well in our hospitals, and because most of these infections are acquired in the hospital, they are also multi drug resistant, so management of these infections incurs huge cost to the patient, and sometimes also leads to very high mortality. Next slide, please. Different factors which are prevalent in India as well as other low middle income countries contribute to emergence of drug resistance. The most common example is a poor doctor to patient ratio, non-availability of clinical pharmacists, infection control nurses, suboptimal lab capacity, absence of ID physicians, preference of broad spectrum over the narrow spectrum, behaviors like self-medication, non-adherence, non-compliance, they all lead to emergence of drug resistance. India is also has a huge pharmaceutical industry, and there is unregulated use of antibiotics. Although government has initiated many steps like H1 schedule or availability of antibiotics only on um, uh, availability of prescriptions by the doctor, yet there is still a gap in the implementation of these practices, which leads to over-the-counter availability of drugs, counterfeit drugs, also inappropriate fixed drug combinations. Suboptimal investments in diagnostics are also correlated with emergence of drug-resistant mutants due to overuse of antimicrobials. Next, please. So, at the receiving end is the patient who ends up, and the healthcare system. Patients end up paying for a higher cost of treatment. There are prolonged hospital stays, increased mortality, and the most important is, the resistance selection, which leads to further evolution of drug-resistant bugs. Next, please. Next. So, suboptimal investments in the healthcare system, in diagnostics, infection control, absence of skilled human resources, they all lead to inappropriate prescriptions. It is next, please. And also, they lead to development of drug-resistant mutants, availability and unregulated sales. Rising incomes have also been correlated to increasing antimicrobial resistance. Next, please. And the most important is the poor perception of threat. When the community is not aware, when the physicians undermine the threat of the impact of use of inappropriate antimicrobials, their frequency on emergence of drug-resistant mutants, that is where the real problem is. So, in a way, next please, it can be correlated to the climate change, the carbon footprint that we have today, what kind of impact it has on our environment. 10 years from now, it is very difficult to fathom. Similarly, what impact the inappropriate use that we are doing today will have on the antimicrobial resistance rates in the future, that is also unimaginable. Uh, but now there is enough evidence. This is evidence from low middle income countries. As you can see, the global antibiotic consumption rates, if we see India, China, and many other countries will be the highest. They have been and will be the highest consumers of antibiotics in years to come. Next slide, please. We already know that in India, antibiotic consumption has been rising, and especially, next please, the sale of broad spectrum antimicrobials like quinolones. It increased a lot first few years. Now it has come down because we are already seeing development of resistance to quinolones. Cephalosporins are now being prescribed very frequently. Next slide, please. Ofloxacin regimens are very common. Then this is something that I would like to highlight. This is the prescription trend of ferropenem, which is an oral antimicrobial. It is not actually a carbapenem. Next, please. But it has cross resistance with carbapenems. And ever since the ferropenem introduction in the country, we are seeing a sharp increase in resistance to carbapenems because of its cross resistance. Next, please. So WHO classifies antimicrobials into four broad categories. The access, which should be available at all times. These are narrow spectrum antimicrobials, watch, which should be recommended once, as the first or the second choice of treatment for small number of infections, and reserve should be considered as a last resort option. Next, please. What we see is that India consumes a lot of broad spectrum antimicrobials. In fact, our consumption has doubled in 15-year period. Ceftriaxone is the most commonly prescribed, followed by piperacillin tazobactam. We prescribe a lot from the watch and the reserve category. Watch contributed to 55% almost prescriptions, and this is in 2022 data, while the access contributed to only 27%. So this is something, next please, which we see repeatedly, study after study, that we prescribe a lot of broad spectrum antimicrobials. And as a result, we see a lot of MDR pathogens in the ICMR AMR surveillance network. In fact, we have classified the pathogens in three groups. First, require aggressive action, which includes carbapenem-resistant enterobacterials and Acinetobacter baumannii, drug-resistant Salmonella typhi, and Candida auris. Group 2 includes ESBL-producing enterobacterials, MDR, Pseudomonas aeruginosa, VREs, azole-resistant Candida. And Group 3, which requires continuous monitoring and prevention, is MRSA, azole-resistant Aspergillus fumigatus, amphotericin B-resistant Aspergillus, drug-resistant Strenotrophomonas maltophilia, colistin-resistant enterobacterials, and Acinetobacter. Next, please. If we look in India, there is a lot of prescription of fixed drug combinations of antibiotics, and this is one survey which was undertaken from 2011 to 12. It increased from by 26% from 2056 million to in 2007 and 8 to 2583 million in 2011-12. And most of this is in the fixed drug combinations, and the single drug formulations only increased by 20%. Similarly, the increase in access group was 20% higher from 2007 to 8. But the watch group grew a lot, almost 73%, and the reserve group antibiotic increased by 174%. Next slide, please. So this really doesn't augur well for our antimicrobial resistance trends and rates. Government had at its own level tries to take action. They have enacted H1 schedule to regulate sale of antibiotics. Time to time, we try to share inappropriate fixed drug combinations list with the CDSCO, and they have been able to ban the FDCs, inappropriate FDCs twice in last 7-8 years. Then there is now a ban on the colistin as a growth promoter. Next slide, please. So coming to the topic of substandard and falsified medicines and what role it plays in emergence of AMR, almost 10% of antimicrobials used by human in low and middle income countries are estimated to be substandard, and they are also considered important drivers of AMR. Their understanding of their relationship, although remains rudimentary. In Southeast Asia and Sub-Saharan Africa, the prevalence of substandard drugs is more than 50%. And knowing true extent of the problem is difficult as sampling is uneven and potentially unrepresentative. Next slide, please. So, because of the presence of insufficient active ingredient, substandard antibiotics may not have enough active substances to treat the infections, which leads to emergence of drug-resistant mutants. Then, even if there is enough antibiotic to stimulate bacteria, it can be harder to treat with high-quality antibiotics, the resistant bacteria. Then bioavailability can be a problem. The other effects of substandard antibiotics are worsening clinical outcomes, adverse drug reactions, economic loss, and diminished public confidence in the health system. Next slide, please. So this is a very important issue, and what we can do now is we strengthen our regulatory systems so that these products are not approved in the first place. Then secure the supply chains by improving the global medicine supply. It ensures the quality of products and practices everywhere, including LMICs, are uniform, thereby helping to combat AMR. Besides these, we can support global and domestic procurement practices to ensure availability of quality medical products, including antimicrobials that can help and prevent and slow the spread of AMR. We will be hearing more about this in the subsequent talks. Next. So I think this is my last slide. Thank you everyone for your attention, and thanks once again to Dr. Shobha for giving me an opportunity to share my views on this topic.
Thank you very much, Dr. Walia, and thanks for sharing the causes, challenges, and implications of AMR, including poor perception of the threat of AMR, which again is an important factor, unless the common public also understands and demands more action on it. And of course, the role of medical practitioners and also hospital-acquired infections. Thank you very much. Moving forward, I now invite our friend, mentor, and guide, a noted global AMR expert, Dr. Philip Matthew from the World Health Organization headquarters, AMR Awareness Campaigns and Advocacy team. Philip will help us understand the work of the WHO on substandard and falsified medical products and their link with AMR. Welcome, Philip, and over to you.
Thank you so much, Shobha. I hope I am audible and you can see my screen.
Yes, we can, and you are very audible. Yes.
Thank you. Thank you. And thank you so much, Shobha and CNS and the Global AMR Media Alliance for this invitation. I'll keep my presentation as short as possible, just to introduce a couple of products that WHO has brought out outlining the extent of the problem of substandard and falsified medical products, and what are the basic learnings for antimicrobial resistance. So if you look at the definitions that are followed globally, which was endorsed by the World Health Assembly in 2017, they have defined substandard, also commonly called as outer specification, as authorized medical products that fail to meet their quality standards. So it can be some manufacturing error, it can be expired or even degraded products after expiry dates. Then there is a huge category called falsified medical products, which are basically fraudulent. These are medical products that are deliberately or fraudulently misrepresented based on their identity, composition, or source. And then we have unregistered and unlicensed products which have not undergone evaluation or approval by the relevant national regulatory authority in the market which they are marketed. So these are three different, discrete, distinct categories that we should be aware about. And I think you've, in the beginning, you had outlined the extent of the problem. Globally, especially if you look at low and middle income countries, 10.5% of the products are actually supposed to be falsified or substandard. The failure rate is 1 in 10. Which sometimes will be an underrepresentation also because of an obvious reporting bias in many countries. And in developing countries alone, this leads to a total impact of, or rather the cost of this substandard and falsified medical products works out to be approximately 30.5 billion. Again, it can be across underrepresentation. And in terms of child mortality per year, if you look at specifically the case of under 5 pneumonia, the approximate estimation of mortality is between 70,000 and 170,000 per year. So you can see the extent of the problem. 1 in 10, 30.5 billion US dollars per year as direct losses to the economy because of this, and also the extent of its impact on mortality. So it's a multidimensional issue driven by several drivers. Starting from weak regulatory systems that we see in several developing country contexts. We have the supply chain complexity, which affects interventions to prevent this. We have the lack of access to affordable medicines, which forces people to access suboptimal, informal sources for antimicrobials. We have, or rather for all the medicines, we have weaker health systems. If you don't have universal health coverage, people have a higher proportion of out-of-pocket expenditure, and people will actually look for options to cut down their medical expenses. And informal sources are relatively cheaper than formal sources. So all of this contributes to substandard and falsified medical products. And of course, it's complicated by the general corruption, levels of corruption, and low consumer awareness and education. Coming on to antimicrobials, this is taken from a report published by WHO last year. This is from the Global Surveillance and Monitoring System for Substandard and Falsified Medical Products, which is managed by WHO. And this is the data between 2017 and 2021. You can see that anti-infectives for systemic use contributes most to the global statistics on substandard and falsified medical products. I'm not able to find an actual proportion, but if you look at it, it's much more than drugs used for nervous system use, or even anti-neoplastic drugs and cardiovascular system drugs and any other category of medicines. And most of it is actually coming from developing countries, predominantly from the WHO African region, followed by the region of the Americas. So you can see it's a huge problem for antimicrobials, and it's a huge problem for antimicrobials consumed or marketed in developing countries. So again, what is the pathway? If you look at it, I'm grateful to Dr. Kamini for explaining the pathway very clearly, but just to reiterate it, the subtherapeutic concentrations of antimicrobials can actually result in antimicrobial concentrations below MICs and also selection pressure, which again contributes to antimicrobial resistance. Again, looking at the second major pathway, no active ingredients in medicines, the so-called medicines, in the case of falsified medical products, leading to persisting infections, leading to greater morbidity, leading to greater likelihood of emergence of resistance, and also its transmission. Again, all of it can lead to greater mortality, morbidity, loss of income, increased healthcare spending, economic losses to the country, and also especially public mistrust in formal systems of medicine. We are seeing greater levels of mistrust in public health, in formal healthcare delivery systems after COVID-19, but all of this can actually contribute to it. Again, the challenges, I think the major challenge on how to deal with this is the complexity of the value chains and the supply chains of medicines. So if you look at, I've just taken a diagram to demonstrate the complexity of production and dispensing and use of medicines in an average health system. But in the case of antimicrobials, it's even more complicated because before the manufacturers, you need the active pharmaceutical ingredients. And we have data to show that active pharmaceutical ingredients are also highly concentrated in a few countries. So even if the manufacturing is happening elsewhere, you have the APIs coming from a different country. So, and then it goes to the wholesaler, it goes to the pharmacy, it goes to the private clinics. It can go directly to a procurement system. If in the case of public health systems, it can go to central medical stores, it can go directly to hospitals. So the system is so complex that the interventions are very, very challenging in many contexts. And WHO has put together two systems to actually deal with it. One is a global surveillance and monitoring system, which is essentially a reporting system to compile intimations from countries regarding substandard and falsified medical products. And the second is a member state mechanism, which is basically a platform to share resources and also best practices between countries. And broadly, the principles for a robust global response to substandard and falsified medicines is to improve the regulatory capacity in the country. The national regulatory agencies play a very crucial role in preventing and mitigating the problem of substandard and falsified medicines, followed by legal frameworks which are up to date and also harmonized, because medicines can be authorized by multiple regulatory agencies in countries. So a very harmonized system within the country is essential to actually make sure that these regulatory agencies do talk to each other and the quality standards are also aligned. We also need collaboration, not just within a country, internationally, and a robust system of information sharing. We need, of course, the technological solutions. I sincerely hope that the Trinity Challenge, funding round this year will actually result in some very good technological solutions that are feasible to be implemented in developing countries. And of course, we need to support the healthcare providers and also inform the public about this issue of substandard and falsified medicines. It's not in the public domain as such. People are not really worried about substandard and falsified medical products, even when there is very, very good quality data to show that the extent of the problem is huge in the developing country context. I'll deal with one more specific issue. Is about antimicrobial shortages or general shortages of medicines across healthcare systems in developing countries. Again, the basic definition that we use to differentiate shortage and a stock out. Shortage is basically insufficiency to meet public health demand and patient needs, while shortage is the complete absence of the medicine or the health product at the point of service delivery. So these are again two different entities. And unfortunately, antimicrobials are very much affected by shortages and stockouts. We've seen huge shortages and stockouts for penicillins and first-generation cephalosporins globally. And even very basic antibiotics like nitrofurantoin, there have been reports of stockouts in several countries. So a lot of access antibiotics are actually affected by shortages and stockouts in many countries, and we should be concerned about it. Again, how does it affect AMR? Of course, no treatment will mean interruption of the treatment regimen, which will mean suboptimal dosing or treatment duration, again, allowing bacteria to develop resistance. Low quality treatment leading to poor, to treatment failures and development of AMR. Depending on the product content, wrong treatment. People and healthcare providers are forced to actually use broader spectrum antibiotics or antibiotics on higher tiers of the AWARE classification. Dr. Kamini had mentioned about the Access, Watch and Reserve classification that WHO has proposed for antimicrobials. So if an Access antibiotic is not available, if there is a stock out, people will actually use a watch antibiotic or even a reserve antibiotic. Again, exerting a wider selection pressure to develop antimicrobial resistance. Again, slower treatment is also a possibility. People take the correct antibiotics too late. So there is a higher likelihood of developing AMR. Again, what are the common reasons for shortages? It can be global, national, or subnational in its scope. Globally, there have been some global supply chain challenges, especially during and after COVID-19. Um, these are primarily related to supply chains for active pharmaceutical ingredients. We've experienced national shortages driven by procurement issues. Some price points have become higher after COVID. And again, there seems to be inability to predict demand in several contexts. So again, leading to shortages. There can be seasonal fluctuations. There can be annual trends in actually demand for antimicrobials, and the prediction capacity or the demand forecasting capacity can be a problem in many countries. And then there are subnational shortages, again driven by inefficient distribution and inventory management systems. It can be the lack of visibility of products of suboptimal or unknown quality. And it can be even driven by healthcare professions, people's preferences for certain antibiotics or people not following standard treatment guidelines. And GATP and WHO has recently come out with a set of policy and regulatory interventions to address antibiotic shortages. It's available online. You can search it. And I've taken this slide from that report. Again, it kind of gives an outline of the measures to prevent and mitigate shortages, starting from enhanced flexibility for acute shortages. In a healthcare system, whether there can be some kind of procurement flexibility, distribution flexibility during shortages to increase the product availability in centers or in specific geographies. It also gives an outline of how we can actually strengthen the sourcing part of it by anticipating shortages and also diversifying the sourcing mechanisms. Can we increase visibility and information sharing on potential or existing shortages of medicines? And how can we institutionalize collaboration, whether it can be about best practices, information sharing, or even transfer of medicines in acute situations where there is shortage in one part of the health system or in one country? Can we actually make sure that there is horizontal transfer of resources? And how do we strengthen the basic foundations, including the National Regulatory Authority? So it has given a very good outline of the interventions which are possible. And also it prioritizes interventions based on the complexity measures required for these interventions. So it'll be good, if you can actually browse through the report. It'll give you a very good idea of what is the extent of the problem and what can be done with in relation to antibiotic shortages. So I've basically tried to give you an outline of three different things: substandard, falsified antimicrobials, and antimicrobial shortages or stockouts, and how does it affect antimicrobial resistance. So thank you so much for your time, and again thank you to CNS and the Global AMR Media Alliance for this opportunity. Back to you, Shobha.
Thank you very much, Philip. Very grateful as always. And thank you for talking about the direct losses to economy and also to human lives. Means both are important for us. Human lives are more important to save, and of course, the loss to economy due to substandard and falsified medicines. And thank you for also pointing out the reasons of weak regulations, lack of access to medicines, and low awareness in general public. Thank you very much. And if there are any questions for Philip and Dr. Walia from the audience, we can take them up now. Participants, please type in your questions in the chat box. We already have questions for them. Question for Dr. Walia is from Anjali. Are women and other gender diverse people more at risk of AMR? like access issues could be greater for them, perhaps. Dr. Walia.
Yeah, can you repeat the question, Shobha?
The question is that are women and other gender diverse people more at risk of AMR?
Yeah, I mean there is a lot of evidence which says that women are more prone to drug resistant infections because women also have more exposure to healthcare facilities, for example the childbearing and other such events. They lead to more women getting more exposed to drug resistant pathogens, and that's why this is a concern that women should be more aware of these problems, and also should understand the threat around it.
Okay, thank you. There's a question from Patricia, which is to both Dr. Walia as well as to Philip, that we in many low and middle income countries are struggling to right and timely diagnosis. And unless we strengthen lab capacity and make sure that it is accessible, how will we be able to address AMR? And then she goes on to say, in many TB high burden countries, for example, diagnostics, which has potential for multi-disease, is limited to just TB. How can we scale that up? Yes.
So in India, there is a lot of focus to make diagnostics available in all levels of healthcare. I am myself leading development of essential diagnostic list, which makes it mandatory for culture system to be available, culture facility to be available in the district hospitals. And we see a lot of positive change happening where the states are now procuring culture systems, this facility is being made available, then microbiologists are being hired for the district hospitals. So I think the challenge going forward will be to sustain this focus, and also sustain the implementation for of the diagnostic facilities at all levels of healthcare. But in India, for India, I can say there is also a document which is the Indian Integrated Public Health Laboratory. Yeah, all the district hospitals will be converted into IPHL labs. So there's a good amount of understanding that the diagnostic infrastructure has been suboptimal and it needs to be strengthened, and sufficient funds and focus is there on this issue now. Over to you, Philip.
Thank you, Dr. Kamini. Just to reiterate what she just said, I think there is a global deficiency in laboratory services, especially for bacterial and fungal infections, and that is affecting the quality of treatment globally. So that lab strengthening is a necessity that we should actually prioritize. And the second part of the question was, whether we can actually have utilize these multi-pathogen versatile diagnostic platforms. Yes, I think WHO, like at least my colleagues in the working on lab strengthening are already in discussions with several manufacturers to prioritize the pathogens for many of these multi-pathogen diagnostic platforms. So I think there has been a lot of work done in this regard, but a lot more needs to be done. So I totally agree with your suggestions that lab strengthening is a priority, and of course we should utilize as many diagnostic platforms available for doing so. Thank you, and back to you.
Thank you. And there is another part to the question, that doctor shortage is also important to remember when we say regulate medicines. So what can be done about that? Philip, would you like to say?
Of course, I think that's the fundamental problem that we are dealing with in the context of AMR is the lack of systemic capacity. It can be evident in multiple shapes and forms. It can reflect, or it can be evident as lack of capacity for regulation. It can be healthcare delivery capacity. It can be access-related challenges. But the systemic deficiencies are common for all these different challenges. So I think one of it is reflected in the doctor population ratio, or many statistics around health worker to population ratio. So again, it is a challenge, but it doesn't have any short-term solutions. It's a long-term challenge related to health workforce capacity. And in many countries, the ratios are getting better, but it's very slow. The process is very slow. So in the meanwhile, what can we do is a question. So WHO has been working on strengthening existing health capacity and making sure that the people who are graduating out of medical schools are competent to actually use antimicrobials properly. So we have come out with curricular guides. We have come out with several curriculum assessment tools. We have come out with competency frameworks, not just for healthcare workers, but even we are even coming out with one on community health workers. So what can we do to capacitate the existing workforce is a question that we are actively dealing with. And again, the long-term solution to it is actually having more healthcare workers, more doctors, more community health workers who are competent enough to actually deliver good quality healthcare, including appropriate use of antimicrobials.
Thank you, Philip. Zafar Kidwai wants to know that even medicines where we know people who are on them for long term, they are facing shortages, like for TB, HIV. So how to ensure quality medicines and that they are available uninterrupted?
Again, I can go first and then probably.
Yes.
So again, a part of my presentation was about how we address antimicrobial shortages and stockouts. So again, there's no one size fits all solution. It is again a multidimensional problem related to sourcing, to supply chains, to demand forecasting, to a lot of things. So there is no one solution to it. But I think the basic aspect of the common feature of all the solutions is basically strengthening the capacity of the national regulators and making sure that the supply chain weaknesses are addressed and strengthened, and the supply chains and the value chains are strengthened. And of course, the supply chains are as diversified as possible. So, think about manufacturing capacity, local manufacturing capacity in countries. There has the UN system, UNCTAD, has done a lot of work on increasing the manufacturing capacity for antimicrobials in the African continent. They've published a couple of reports. They've looked at the financing options which are available. So there's a lot of work happening in this regard. But again, it's very multidimensional, and the fundamental work to be done is to actually strengthen the national regulatory capacity.
Thank you. Dr. Walia, would you like to add?
Yeah, I think two key challenges here are the funding and the demand consolidation. And it is very important because now we are seeing, the USAID funding being taken away. So it is going to impact the programs which were being funded by USAID or other donors who were in turn receiving funds from USAID. So this is going to be a major setback, especially for the programs on donor funding. So for that, I think the more reliance we have on our own funding, the more will be the stability and sustainability. And that's why the countries need to allocate more resources for their own patients and for their own programs, and have less and less reliance on the donor funding. The second is, as Philip very rightly pointed out, the demand consolidation. Understanding that, how many patients we have, how many dosages we need every month or every year, having the more stable supply chains, how can we have that? So that kind of thing can be supported by a better digitization of the healthcare systems. And that's why I think for having the seamless supplies, for having more stability in terms of these treatments, it is very important that we have the digital dashboards being there, through which we are able to monitor the supply. So these two things, I think, will be crucial to maintaining a good supply chain for the patients who are on treatment, and to prevent any outages or short supplies.
Thank you. Then there is another question from Dr. Sudeep, that do you think the existing WHO global surveillance and monitoring system is effective enough in addressing substandard and falsified medical products related to AMR, especially in the low and middle income countries? Philip, would you like to say something to that?
It's a very difficult question, but I think that's the best we have right now. Of course, there are challenges and deficiencies, in every system, and there is, any global data repository or data collection systems, there will be a reporting bias in many countries. Many of these global systems are based on reports coming in from countries, and with obvious reasons, there will be some kind of what do you say, inhibition at the level of countries to actually report about the quality challenges with medicines, because it'll also reflect on the quality of the national regulatory apparatus and the national regulatory system. So there will be a reporting bias for sure in any of these global repositories. So and that is a challenge, as Dr. Kamini was saying. Many of these things are underreported, and many of these global statistics are not essentially correct in that sense. So I want to put together a diplomatic answer to it. This is the best we have right now, but of course there are challenges, and it requires a more robust system to make sure that whatever reports are coming in from countries are actually based on a proper sampling. It shouldn't be a passive reporting. It should be a more active form of reporting happening based on an active surveillance in countries. So that's the obvious way to go. But the present system is quite good enough, especially if you look at the quality of reports coming in on antimicrobials. It's dominated by reports on malaria. If you go through each of the individual entries, most of the reports are actually about malaria, not so much about the other antibacterials. So if you're specifically asking about antibacterials, the antimicrobials that we are dealing with, I think more can be done at the country level. So it's a complex answer. Hope I could actually coherently put forward a sufficiently good answer for you. Thanks.
Okay. We'll take up one more question. This is from Kidu Hailu, who is from Ethiopian Pharmaceutical Association. And Kidu says, we face challenges to build the capacity of pharmacy professionals working in community pharmacies, while the lion's share of antibiotic dispensing without prescription is believed to be from these. Development partners and the government primarily work on the public health facilities. What do you advise us?
I can take
agree
this.
with the... Philip, go ahead, please.
No, please go ahead. Please go ahead.
Okay. So I agree with the point being made that we are not engaging pharmacy professionals in these discussions. At least in India, I still have to see something being done at a national level. I mean, there are studies which have been reported, but they are very small studies and do not really do justice to the vastness of the country. From our own personal experience of working with the tertiary care hospitals, we have seen the importance and the difference that it makes to have pharmacy professionals involved and review the prescriptions. So I'm talking about the clinical pharmacists here. I think the comment referred to the pharmacy professionals in the retail pharmacies. And it is important to have both. We need clinical pharmacists who can guide the clinicians on the right dosages, the right duration of the antimicrobial, also any kind of adverse effect reactions to the medicines which are prescribed alongside the antimicrobials. All that is very, very important, and we need clinical pharmacists. And for all the hospitals where we are working with the tertiary care hospitals, we do provide a clinical pharmacist, and some of the hospitals have continued to engage them post the completion of the project as well. This kind of highlights how important the clinical pharmacists are to the specificity of antimicrobial prescriptions. Regarding the pharmacists in the retail pharmacies, I think we need to carry a nationwide awareness campaign to raise awareness of this group of professionals. Over to you, Philip.
Thank you, Dr. Kamini. I think the experience from India is relevant for a lot of other parts of the world. Coming straight to your question about how pharmacists can be engaged, I think we at WHO, we are trying to involve as many international pharmaceutical bodies as possible, starting from FIP or IPSF. That has actually resulted in a large network being very sensitized about the issue of antimicrobial resistance and the appropriate use of antimicrobials. So that being said, over-the-counter medicines is a huge problem in many parts of the world. We were actually thinking about, or rather exploring the possibility of launching a global campaign against over-the-counter use of antimicrobials. We had a big consultation meeting happening in Geneva, but then finally we decided not to go forward with the global campaign because the complexities are so huge. Like one example given to us by one of the people attending that consultation was that 50% of all doctors in Kenya are based in Nairobi. So if you're asking a mother with a sick child, say in a remoter part of the country, probably somewhere in Nakuru, to actually get a prescription for every antibiotic, it's practically not feasible and can be counterproductive also in many instances. So when the health systems are challenged, when there is huge differences in the strength of health systems, even within a country or even within a county, having a global campaign against over-the-counter use may be counterproductive. So the way out, at least in the short term, will be to actually empower and make sure that the pharmacists are aware about antimicrobial resistance, and also the dispensing pharmacists and community pharmacies are actually competent enough to actually differentiate a viral and a bacterial infection requiring referral. So those are the obvious solutions that we have on the table. But again, a long-term solution is to phase out all kinds of over-the-counter use, starting with the watch and reserve antibiotics. Back to you, Shobha.
Thank you. Now, just one last question. Promise from my side, one last question. There are two questions similar to each other. Kalpana Acharya, a very senior journalist from Nepal, wants to know, how can we ensure the quality and safety of over-the-counter medicines, especially when their regulation and monitoring is weak? That is, how can we, the common public, those who are buying the medicine? And also, a similar question from Semjidama Choiji, who is Executive Director, Psychological Responsiveness NGO, that in low-income countries, there is poor quality of lab and supply chain has no control. How can we identify the quality of medications? What do you advise? So, Philip, would you like to take it first? And then...
Sure. Again, the onus of identifying a poor quality medicine is not on the public. It's on the system, primarily on the regulatory system, right? So it should be strengthened, and that's the most obvious answer to it. If the national regulatory authorities have the capacity to actually differentiate and weed out poor quality medicines from the system, that's the best way forward. And second, obviously, the public should be aware about an issue of quality of drugs, but the responsibility of making sure that the drugs available in a local retail pharmacy is of sufficient quality is not on the public. So we should be able to differentiate that function. Again, the second question was about the lack of laboratory capacity. How do we do it? But there are so many technological solutions available, and many of these laboratory requirements for identifying quality of medicine issues are not that complicated. Of course, sometimes you need very complicated laboratory systems, but at the same time, in many cases, identifying falsified medicines don't require such complicated, sophisticated lab systems. There was a project run in many parts of Africa. It's called Mini Lab. If you actually search for it, it comes in a box. MSF, the Doctors Without Borders, actually used it extensively across Africa. So you can actually differentiate a poor quality medicine from a sufficiently or a medicine of sufficient quality based on very, very few physical characteristics, which can be differentiated based on this small box. So many of the interventions, do need to be very practical and feasible on the ground. And this mini lab system has demonstrated efficacy of such very practical on the ground systems. I can put a link to that in the chat box for your information. So what I'm trying to say is the regulatory systems should be strengthened, and these kind of innovations which can help on the ground regulators to differentiate. These are obviously needed in many contexts to actually differentiate it. Thanks.
Thank you. Dr. Walia, would you like to add to that?
I have no additional comments, Shobha. Philip very nicely covered all the topics related to this question.
Okay. Thank you very much. Thanks to both of you. Please stay on. And now we move on to the next part, that is health science and technologies are really not enough. We need to ensure that health systems are strong and they are people-centered, equity and human rights based, and health justice is a reality for everyone. I'm sure all of you will agree with me on that. So now I would invite one of our personal inspirations for CNS over the years, LEENA MENGHANEY, who has dedicatedly worked for all her work life. We have known her to ensure access and rights, life-saving medicines with equity and rights for everyone. LEENA is a noted lawyer and a consultant for public health, pharmaceuticals, and access issues. Welcome, LEENA. Over to you now.
Thank you very much. I hope you can hear me clearly.
Yes, very
I'm
clearly.
just confirming that, yeah. So wonderful to be here. I just wanted to say that coming from working very closely with communities, I can't reiterate the importance of antibiotics in our lives, and of course for very marginalized communities. If you look at projects in Bihar, for example, for advanced HIV, one of the biggest killers for people living with HIV, with advanced HIV disease, is antimicrobial resistant bacterial infections. So you have a situation where a lot of us are impacted directly by the lack of access, but as well as drug-resistant infection. So I just wanted to highlight these two issues. Ironically, I'm sitting in the hospital where my father's been hospitalized for pneumonia, and I think increasingly community-based groups should be invited to design interventions that are suited to their very particular needs in the communities that they work in. And in that context, I wanted to talk about what we can do about the quality of medicines. So a large part of quality of medicines has always been left to regulation, to governments, to the drug regulatory authorities. And I just wanted to illustrate how communities can play a role in alerting drug regulatory authorities and programs on substandard medicines, or medicines of unknown quality, if they have a concern that the quality of medicine is at stake. This year, when people living with HIV in 2024, it started in after a new batch of medicines was delivered, and a number of people came forward from among the HIV networks to report that they were getting reports of the pills being very bitter. And as we started to talk to people living with HIV, they also reported that the pills were breaking. And we used the testimonies of people living with HIV to write a letter to the Drug Regulatory Authority and the health ministries. The health ministry and the Drug Regulatory Authority took action within a week. And we realized that they had withdrawn the medicines, and they had, reinstated supply with a WHO pre-qualified supplier. So this was something that we very actively tracked in the field as communities affected by HIV, and reported it right directly to the program and, of course, to the drug regulator in India. The second thing I wanted to say is this, that often, procurers are dependent on QC systems. That means they take some samples from a particular batch that is being delivered and test those samples. And those samples can tell you two things: if there's contamination and there's enough API, which is the raw material that goes into the making of the drug. But what it doesn't tell you is that whether the drug is bioequivalent, it is stable enough to withstand heat, for example, in countries like India, where temperatures can touch 49. It doesn't tell you whether those drugs will remain stable in very high humidity, and all of those issues. So we know that currently procurers and health ministries have invested in QC systems. And what we want health ministries and procurers to do is to treat quality as a process. That means procurers can play a role by coming together to define that what the quality that they are want to procure have certain characteristics. For example, for some drugs, they would require bioequivalence. Certain drugs that are classified under the BCS as 2 and 4. You would need bioequivalence. You would require certain months of stability data. You would require the API to be from a WHO pre-qualified source or a source that has been well inspected by your National Drug Regulatory Authority. And these are these small steps that community can play towards demanding that their medicines meet the quality that is needed to ensure that they are treated, that the treatment works for them. So these are some of the illustrations I wanted to highlight. And in that context, I wanted to say that our experience has been with HIV and TB, that we have recognized the lacuna and the weaknesses in national drug regulatory authorities and the ability to ensure that all the drugs available in the market are of the quality that, of a quality that would ensure proper treatment. But often there are gaps in a regulatory system. There are lack of resources, there's a lack of training. For example, regulatory authorities in Africa find it very challenging to inspect raw materials from China that are going into finished formulation. This is a challenge that regulatory authorities face. In India, you have 29 drug regulators. You have the central drug regulator and you have 28 other drug regulators. So how do you overcome these time-based challenges? That means changes are going to happen, improvements are going to be made to quality, but they're going to take time. That's where procurers can play a huge role by creating a network at the national level, at the regional level, at the global level. And this is what happened for people living with HIV when we demanded that the medicines that the Global Fund was buying or funding countries to buy should be WHO pre-qualified. And this is something that we need to do for antibiotics as well. And just to give an example of how we can be more alert and as communities more able to understand issues of quality, if you look at the recent tender document from the Government of India, the National TB Control Program, there's a tender document on new TB drugs. This is a single tender document, which is available in the public domain. And for all the 3 new drugs, there are different quality standards being prescribed. So this is the big challenge that we have, that procurers often don't know the difference between WHO pre-qualified products, something that is registered at the state level, something that's been registered by the national level. Sometimes procurers don't know something might be registered by the US FDA, maybe registered by the Brazilian FDA, and that source of antibiotic will be much better. So I just wanted to sort of highlight that while we encourage our governments to put more resources into national drug regulatory authorities, there are certain things that communities can do. And the last point I really wanted to emphasize is this, that the biggest challenge today is not so much as falsified or fake drugs. The biggest challenge is antibiotics of unknown quality. We do not know what the quality of the antibiotic that is being supplied to health system, whether it's of quality or not, particularly in resource poor settings. And this is, I think, the biggest challenge we need to define and need to start, demanding changes for. And in that context, I think some of the experiences that we've had from TB and HIV have been particularly useful. The last point I wanted to say is that, yes, governments are very, very conscious of preserving newer drugs, but often not conscious of the lack of access to older medicine. So penicillin was one drug that was needed for STIs, and the National HIV Program really struggled with procuring it. And finally, they consolidated the demand and they put in a request to one of the manufacturers that, the Government of India actually, it's one of our public sector manufacturers in India. The consolidation of the demand for penicillin helped the HIV program get access to a very important antibiotic. And that's been, I wanted to sort of stop my talk on that you can work towards consolidating of demand and making sure access is possible, particularly for very vulnerable communities. And I'll stop here. Thank you.
Thank you very much, Leena, and thank you for bringing into focus once again the importance of community participation and work from the community, which has proven to be so very important, particularly in the field of HIV, as we have seen, and also for pointing out the gaps in regulatory authorities of countries and how to overcome them and what role procurers can play there. Thank you very much for being with us today. And all force to your father coming back to good health. I hope his condition is improving. Sorry to hear about his being in the hospital. Thank you. Thank you for being there. And now, friends, hold your breath to hear more about the 1 million Great British Pound competition of the Trinity Challenge to improve community access to effective antibiotics. We have with us HAMISH MORROW, Project Manager at the Trinity Challenge, to introduce this. Welcome, HAMISH.
Thank you so much for having me. Can you see me and hear me okay? And see
Yes,
my...
we can see your
Perfect.
slide, we can hear you, yes.
Fabulous. Well, thanks so much for having me. As you say, my name is Hamish Morrow. I'm the project manager here at the Trinity Challenge. Thanks to GAMA and CNS for the invitation to join this dialogue and present. And of course, thanks to the speakers for their insights on these important topics. So as per Shobha's introduction, I'm here to provide you with a brief overview of our £1 million Innovation Challenge, the Trinity Challenge, on community access to effective antibiotics. But first, for those that aren't aware of the Trinity Challenge, let me very briefly introduce you to our work as a charity. So the Trinity Challenge is a UK charity set up by Dame Sally Davies in 2020 to support the data-driven solutions to help protect against global public health threats. Some of you may already know Dame Sally is the UK Special Envoy on AMR, as well as being the Master of Trinity College, Cambridge. She's a prominent figure on the world stage who's passionate about driving for change in the antibiotic emergency. So our work revolves around identifying innovators from around the world whose use of data and technology can enhance our readiness to both act and defend against public health threats. Innovation challenges are our main area of support, but we also support a portfolio of advocacy and research and campaigning activities. Since 2021, we've funded over £10 million worth of innovative projects, impactful projects from around the world, and that figure is set to rise with our new challenge. Our last two challenges have focused on antimicrobial resistance, which of course is the theme of today's talks, and in relation to that, connecting the dots, the Trinity Challenge very much is a connector between this really critical issue and the innovators who can hopefully provide a solution. So very briefly, our last challenge, which was the precursor to this current challenge, 2024's Trinity Challenge on Antimicrobial Resistance, was a call for data and technology solutions to combat AMR in low and middle income countries. It received 285 applications from 57 countries and awarded £2.7 million in funding to projects in Vietnam, India and South Africa. So moving on very specifically to the current challenge, the Trinity Challenge on community access to effective antibiotics. So this challenge is a call to action for the world's brightest minds to answer the question that's on screen now: how can data and technology improve stock control and/or reduce the use of substandard and falsified oral antibiotics for community use in low and middle income countries? Over the next few minutes, I'll take you through an top-level outline of the challenge, but you can scan the QR code on screen and it will take you to the challenge page for more detailed information. I'll also keep it at the bottom of the screen in the next slides, and I'll drop it into the chat at the end of my presentation as well, the link. So in line with what we've been talking about, we know there are many factors that play into ensuring community access to effective antibiotics, but we've chosen to focus on two really major problems, the ones we're talking about today, that of stock control and substandard and falsified oral antibiotics. The challenge sets a broad brief, which could be interpreted in a number of different ways, but could, for example, include tracking, reporting, or predicting supply and demand issues in the supply chain, or innovations around identifying or analyzing the prevalence of substandard or falsified antibiotics. The previous speakers have spoken wonderfully about this issue, and I'm not going to repeat any of the information that they've already covered, but needless to say, we are looking for solutions that either combat both of these issues or take one and focus on it. But as we know, these are interconnected cyclical issues, and they apply to both human and animal health. So what we're looking for are innovations that intervene at any point of this vicious cycle that results in an increase in morbidity, mortality, antibiotic resistance, and with the view of breaking it. So the challenge, as I've already alluded to in some ways, focuses on four main areas. So one is low middle income countries. We're going to focus this on the areas where we know the highest burden of AMR is experienced. We are tailoring this challenge to community level data. So as I'm sure aware, a great majority of our data on AMR comes from high income countries for one, and secondly from formal settings such as hospitals, laboratories, or food production plants. And we're specifically looking for solutions which use or generate data from outside of these settings. So at the community level, which really is a major untouched gap in our understanding. This is one health challenge, and solutions can focus on human, animal, or environmental health, or indeed any combination of these three areas of One Health. And of course, importantly, we're looking for innovation. We're looking for new innovative use of data and technology to combat these issues, or new applications of existing technologies that will rocket our response to the issues. We accept applications really at any point of the development scale from proof of concept onwards. So just to categorize what we mean by proof of concept, we define this as having a prototype which is ready to test and has some preliminary evidence or data that's already been established prior to application. So the only real restriction is that we cannot accept solutions that are wholly conceptual. Your great idea needs to come with some evidenced structure for them to be progressed in the challenge. So what's available and why apply? There are a number of benefits of applying, of course, but the main opportunities that I'd highlight is first, we have a £1 million prize fund available, and we aim to distribute this in 2 grand prizes of £500,000 each. And that will be delivered over a 2-year period. So these projects are 2-year fixed projects. Those 2 prizes, we aim to have one in with a focus on stock control and another on the other category of substandard and falsified oral antibiotics. We also look to engage our members, the members of the Trinity Challenge, to support and enhance winning projects. And in the past, opportunities through our members have included networking, mentorship, and collaborations. Our members are leading philanthropies, institutions, companies, and professional bodies who are actively engaged with the Trinity Challenge's work, and also that of our winners. I'd like to take the opportunity to thank each and every one of them for their continued support, but particularly to make mention of Wellcome and the Institute of Philanthropy, empowered by the Hong Kong Jockey Club Charities Trust, who are making this particular challenge financially possible. Taking a brief look at our timeline for the challenge. So applications are open for approximately another 6 weeks to the 24th of April. You can submit an application on the challenge platform at any point, and you can actually, after submission, continue to refine it after that point, all the way to that deadline at the end of April. So I'd encourage you, if you're interested in this, to start the process as soon as you can and continue to refine it once you're in the system. Once applications closed, we enter into an independent judging process, and we'll announce our winners in August. And as I mentioned before, the winning projects will receive their funding over a 2-year period to the end of 2027. So that's everything from me. I hope you found that an interesting and helpful introduction to the challenge. If you're inspired to apply or would like to know more, there's a few handy links on the screen, but again, I'll drop these into the chat once I finish. And we're also grateful for your help in spreading the news of the challenge within your networks. We have an application Q&A webinar on the 31st of March in a couple of weeks. Do encourage you to join in there. And if you have any questions, you're very, very welcome to reach out to me either on email or scan QR code, and you can connect with me on LinkedIn as well. But thanks so much for your time, and back to you, Shobha.
Thank you very much, Hamish. And audience, please be welcome to see the link of the Trinity Challenge in the chat box. It is there, and you can share it with those who might like to apply as well. We now move to yet another very important part of today's session, which sparks hope and light. Let us listen to those who have actually taken an idea forward to innovation and then onwards to scaling it up and having had a commendable impact on the community. More importantly, all our speakers in this session are from South Asia. Our first speaker is my friend and guide, Mr. Sriram Natarajan, co-founder, CEO, and director of Molbio Diagnostics. Over 30 years ago, Mr. Sriram had an idea of a point-of-care malaria test, and he took it to innovation, scale, and impact, helping save so many lives in the past few decades. He is unstoppable. And decades of hard work of taking ideas to innovation have now resulted, in fact, they resulted a few years back in TrueNat, the world's first and WHO's only recommended point-of-care, lab-independent, battery-operated, and decentralized molecular test for not only tuberculosis, but also for over 40 other diseases. All this magic has happened from the Global South, from India, and is a stellar example where Global South leaders have stepped up to impact change for their own people. Sriram Natarajan has taken ideas to innovations and impacting change and went another step forward to inspire and mentor many people who are at the initial stage with an idea. Welcome, Sriramji, and over to you now.
Thank you, Shobhaji. Thanks for the introduction, and hello, everybody. Very happy to be here, and I must say the last sessions have been outstanding and very big learning lesson for myself. So here I'm coming from the diagnostics point of view, because as a small discussion did take place, there was a need felt for diagnostics that can be engaged at the community level, where you can reach diagnostics to people at the time of the presentation of an infection, so they can be diagnosed appropriately and treated appropriately. So this has been the gap in countries like India and LMIC, where the majority of the population, I would say more than 80% population, just do not have access to high quality diagnostics. And even in the 20% population, which is more urban centric population, most treatment still happens without a diagnosis. So this is the unfortunate situation. And as somebody said, treatment without diagnosis is blind. And that's exactly what's happening. And so that's the reason why we're ending up in situations where people are being either over-treated or under-treated. There's a lot of antibiotic misuse, and it's resulting into antimicrobial resistance. But over and above all that is the unnecessary death of people from completely curable diseases. So this is something which has to be bridged and gapped, and that's where I've been working for a long time, as Shobha pointed out. And happy to talk about our current innovation from Molbio Diagnostics, which is the TrueNat platform, where we have spent about 14 years in trying to completely decentralize molecular diagnostics. Because as you know, real-time PCR is the most reliable and most accurate diagnostic tool for infectious diseases, but it has never been relevant clinically for a long time, just because it was very, very centralized kind of a technology, and people just did not have access to it. And the turnaround time for results also would take about a week, which meant that I didn't have any clinical relevance whatsoever, and never was an initiator for a treatment. So that's where we thought we can play a role, and that's why we worked on this technology. And today we have this platform called Qure.AI, which is a completely decentralized, completely laboratory independent platform where you can actually do a real-time PCR practically at any setting, completely independent of laboratory, with health workers who could be trained very easily and who can do a real-time PCR for about 40 different diseases. So the idea is to look at it from a patient-centric point of view and reach community level kind of engagement, where we're empowering these kind of patients to seek healthcare very early on, so that diagnosis can happen early and treatment can start early, and appropriate treatment. So including even tests which can look for drug resistance, so that you know which drugs are going to work and not going to work, so that right from day one you get the right treatment is the focus. And that's what we are trying to reach. And today, with the capability to do 40 different diseases, this platform is already being used very widely for tuberculosis in India and outside of India. So as you know, that TB is a classical example where diagnostics or the inability to diagnose has been the reason for TB not coming in control, in spite of the DOTS program going on for about 40 plus years in all our countries, just because smear microscopy as a diagnostic tool was not sensitive enough. And a lot of people with TB were not diagnosed, and they were the ones who kept spreading TB to people. Today, of course, WHO has clearly mandated that smear microscopy should be replaced by a molecular test. And that's where we are already playing a big role. And we are one of the 2 WHO endorsed companies for TB diagnosis at the point of care. And a lot of testing is happening in India and also in about 15, 20 countries, TB burden countries outside of India. And we already have a lot of data to show that this is actually significantly increasing case detection and impacting a lot of lives. But while TB, because of the big gap and because of the TB elimination drive, is the focus, but already, the programs are looking at Qure.AI as not just a TB platform, but as a multi-disease platform. We're already seeing India introducing the same Qure.AI platform for hepatitis testing, and the same TB machines are actually being also used for hepatitis. The National AIDS Control Program is now talking about trying to see if the viral load testing can happen close to the patient, so the compliance levels are much better, and so on and so forth. So the platform is being now looked at as a multi-disease platform. Very happy that that's happening now. And as a company, of course, we are committed to make sure that we're able to cover more and more diseases. We already have 30 more diseases in pipeline to be introduced in the next couple of years. So Qure.AI will be, let's say, a platform which can, once put in a primary level, can test for practically all kinds of diseases. And also something which can enable what we keep talking about, the pandemic preparedness. Because once the machines are there and once the infrastructure is created, then making new tests available would be very simple and quick, and will be prepared for any new outbreaks, let's say, or pandemics. So that's what we are doing. And as a company, we're dedicated to continue to bring more and more innovations. We're also about to launch a new platform called Qure.AI, which can do syndromic testing, where you can actually, with one test, look for 16 different pathogens. So you can have different panels. And one panel we are very happy that we're going to introduce soon is the sepsis panel, where people can be identified right in the beginning for the causative organism causing sepsis, and also what drugs will work for it, because as Dr. Kamini had pointed out, this post-hospital infection, which normally is multi-drug resistant. So it's important to know which drug will work. And this will again be a life-saving kind of platform. So this will be our continuous effort to make sure that we're able to decentralize diagnostics, make more and more technologies available to ensure that at the community level, every patient has an access to diagnostics all over the world. I'll stop here and take any questions.
Thank you very much, Sriramji. And I would just like to add that TrueNat was also used extensively during COVID-19 for its RT-PCR testing in very, very remote and difficult to reach areas of India. So all power to you for more ideas, innovations, impacts, and inspirations with equity and rights and with people in the center. Moving forward, I invite Ronika Susan George, Associate Director, Global Health at Qure.AI. Qure.AI is another example of India having a global impact by deploying science and evidence-based machine learning and artificial intelligence to help find diseases early and accurately. Over to you, Ronika.
Hi, very good evening. Can you hear my audio clearly?
Yes, we can hear you very clearly, Ronika.
Thank you so much, Shobha. Thank you so much for having me. I'm Ronika George from Qure.AI. It's an absolute pleasure to be here. I'm the Associate Director for the Qure.AI team, part of the Global Health Sales team. For me, first of all, thank you, Bobby, CNS team, and very happy to follow up to Mr. Sriram. He has been a personal mentor and inspiration as well. And I always tell him that the white hair on his head has been earned the hard way, and happy to have been part of that journey with you, Mrs. Sriram, the past 5 years. And yes, and I think a lot of the learnings that we at Qure.AI have also applied in the early days have stemmed a lot from the inspiration of your bidirectional screening of diagnostics that we applied in our work, and I can touch upon that a little bit later. So really good to follow up to you and be here today. And so I'll just jump right into it. We are Qure.AI, AI here, AI there, AI everywhere. So today, just talking about a little bit about our journey and some of the learnings across that journey and what it took for us to, or what it is taking for us to be building future-ready health systems. So just a quick context background on what we do at Qure. We are an Indian company started in 2016, and we use the power of deep learning, or we use AI technologies to interpret medical imaging modalities from chest X-rays to CTs. And we use this technology to identify and work to screen for diseases across the cascade for both lung health and neurocritical care. The dream is to be a one-stop shop for all things radiology, using the power of AI and augment and support radiologists across the globe. The question is why AI and why now, right? So for sure, for me, what I understand is data will fuel the next industrial revolution, and AI is enormously hungry. And at Qure, we have used a huge data set, one of the largest in the world, of 1 billion images to train our solutions and also screen across the world. We have a very strong regulatory portfolio where we are cleared by CE, FDA with over 20 FDAs. We are also one of the only 3 companies across the world that have been evaluated by WHO as a medical imaging technology that is used for screening for TB, which I'll touch upon a little more. And of course, as a company, we work with many partners across the globe to make sure, be it OEMs or public-private partnerships, to make sure we can make AI-powered solutions accessible to the last mile. And we have a team now, more than 300, close to 100 plus IITians, which is one of the top Ivy Leagues in India. And we have a very global team and strong support that runs our organization. Quickly, this is something that I love, because this, again, like I was telling Mrs. Sriram, has earned and built TrueNat through years of toil. This is our bread and butter, that, how have we been able to successfully bring AI-powered screening solutions to the last mile, be it developed countries like UK, US, Australia, or also working very closely with LMICs and high TB burden countries and high disease burden countries across the globe where access to innovative technologies are not available, and how we have been able to do that now and impact close to 29 million lives and service close to 90 countries in the past 8 years. That is a feat that has given us a lot of learnings of how to bring something from an idea and an innovation and using that data more meaningfully for strong clinical insights and action on the ground. This is the quick recommendation or evaluation document that I was mentioning. We were evaluated by WHO in the 2021 TB screening guidelines, where for the first time WHO has endorsed, or rather encourage users across the globe to use this technology for early screening and triage in the community for active case finding for TB, which like Ms. Sriram mentioned, we know is one of our legacy diseases across the globe. So as a company, we also knew that there are around 4 billion X-rays that are processed every year, out of which close to 44% of these are chest X-rays, and out of these, there is close to 22% that there are discordances between radiologists. So we said, beyond looking at a single disease, how do we actually make the solution more multi-disease and support radiologists across the spectrum? Today, we use the same technology, which is known as QXR, which is a chest X-ray interpretation software. It's able to read X-rays in less than a minute and interpret for close to 30 different abnormalities. We are one of the only companies across the globe that have this multi-disease platform that can look at also pediatric TB, lung cancer, heart failure, COPD, and silicosis. All of these are issues that we have addressed, understanding the needs of the community and how we can address those using this technology. Again, here we process close to 7.3 million scans annually. The AI almost always is very abstract, and how do we make it real for communities is we bring AI in a care coordination platform known as Qure.AI, or an end-to-end disease management app. So now the AI moves from abstraction to an actual tool used by people on the ground to not just register, capture multi-disease pathways, and also capture X-ray and the AI reports, but along with that, complete the loop and capture diagnostics and other information that can eventually feed program decision-making and policy decision-making at a higher level. So of course, there's huge value add of bringing such innovative technologies, not just to address the unmet needs of lack of radiologists, lack of access to services, and growing burden of disease, which is, of course, with the COVID-19 pushed us back, and now with other global conditions are also pushing us back in our efforts and fight for lung health. But the solution has seen a great uptake when it comes at a program as well as at a site level, be it data-driven insights or also looking at how AI can support the clinical decision process. We have used this technology across the spectrum with sites. Today, the main thing I wanted to focus is the cases. Like I said, we have close to 3,900 sites and partners across the globe. We have learned a lot working hands-on with communities in the field, be it the nomadic pastoral fields of Nigeria, or be it the urban cities of Bombay. We have worked across the globe, and these are some of the key learnings. Of course, I tried to summarize it and maybe show you a few case studies in between. The first and most important thing is, of course, that we have to invest in people to amplify impact, because technology without adoption is just a tool. And for us, from moving, we were very technology heavy. We wanted to do everything remotely, sitting in the offices. We thought that one solution that we standardize would work for all. And then we realized all of this needs to be scrapped. And how can we create value on the ground to people to make them use this technology? And hence, we spend a lot of time building strong customer support and working around the clock to answer and support partners on the ground when they use this technology, along with building the capacity and also bringing on board specialists to support the varied, diverse needs in the local community. One example of some of the scale or impact of this work is that today we work with the National Department of Health in South Africa. We are across 100+ sites. We are already screening close to 600,000 patients, population in the community. And this is for active case finding, where we're actually going to hard to reach communities. And this has been game changing when it comes to scaling technologies at a national level. Another one is an example of how working with smaller implementing partners who are doing incredible work hands-on with the community. For example, we worked with Jana Health in Nigeria, where we took ultra portable machines into the community. As you can see in the picture, there is no access to internet, there is no connectivity. We are making, high spec offline systems that can work in these settings and responding to some of the gaps there are in order to make AI more real. Of course, the most important, which Mr. Sriram touched upon, is like going from single diseases and looking at a single patient to looking at it from a more ecosystem lens and looking at how we move from patient screening to a health system screening lens. And that is to inherently say that the AI must serve the system and not the other way around, right? So how do we make the AI more effective? Can we create telemedicine hubs? Can we have ultra portables, fixed sites that use AI speak to each other? Can this be centralized for policy, for program management at scale? Other than that, we're also using the same technology for incidental findings in hospitals, where we are able to identify missed cases where early screening through X-ray would not have been caught. Another important is, of course, looking at comprehensive patient tracking and monitoring. I'll quickly jump to one of an interesting case studies in India that we did, where we looked at how X-ray can be used in hospital facilities, where we screen any patient that's coming in by nature of symptoms or no symptoms. And this was very interesting to identify that we found close to 35% of cases from 9 different facilities in the setup, which were incidentally identified using QXR. For TB specifically. So this is inherently to say that without the technology, close to 35% of the cases could have been potentially missed. And when we look at the potential impact of modeling this at scale, we have seen that if adopted and adopted across, say, 760+ hospitals, we can reach close to 4 lakh missing cases just across India alone. So this has been adopted at scale. Also in the Philippines, we not just look at TB, we have also looked at lung cancer and how we can do that screening. And last but not the least, in terms of the most important aspect here, when we bring innovations to the last mile, is that we need to leverage what's existing, and the best solutions actually meet local needs and don't impose new ones. And here we work, like I said, we upgrade what's already there in hospitals instead of spending on extremely expensive new machines. We see what the countries have and meet them where they are. This is an example of how Kenya has adopted this across 80 hospitals and is screening for multi-diseases currently. So I'll end with just some of our future plans, and excited for all the partners, 100+ partners here. The Trinity Challenge is very exciting. We are innovators, so we get excited with all opportunities for us to expand and support more communities. And we have something known as the Qure.AI that we have recently launched, which is, of course, an AI sandbox that we are extending in our services to test and deploy solutions locally and partner with you basis your needs and your community requirements. And of course, the overall goal and the overall aim of why we do what we do at Qure is to reach 1 billion lives, and that is our ultimate why. So thank you again very much, and open to taking any questions either online or offline. Thank you, Shobha.
Thank you very much, Ronika, and best of wishes to Qure.AI for creating more values on the ground, as you said, and what is needed also. Now let us listen to Dr. Ranga Reddy BURRI. He is the president of Infection Control Academy of India and has led from the front in advancing science and public health responses to infection prevention and control, as well as AMR. He is also on the advisory committee of Global AMR Media Alliance. Over to you, Dr. Ranga Reddy, BURRI.
Thank you very much, Shobhaji. I hope I am heard.
Yes, yes, very clear.
Yeah, thank you. Thank you so much for this very important session which you have organized, and all the team at GAMA for doing all kinds of great things in order to contain antimicrobial resistance. Today, I would like to present one case study of an industry academia alliance, which has been successful in bringing out a new tool in order to cater to the gaps in the diagnostic capacity, which has been identified as one of the major issues. After all the talks, I don't need to probably tell you how big is the AMR problem. I am sure most of the audience here today, they are well aware of the size of the problem, the consequences of the problem, and what would happen if we are not going to deal with this on a urgent basis. And when it comes to tackling this problem, formally 2014 had been a watershed moment when the first ministerial conference on AMR happened. But since then, we haven't really moved much on many fronts. Yes, there had been sporadic kind of instances where some milestones are being recorded, but that did not alter the kind of progression which is happening in antimicrobial resistance problem. There are several challenges, but one of the major challenges and one of the major areas to be addressed is definitely the new therapies and also the diagnostics, where the underfunding is understated kind of statement. We have a very weak antibiotic pipeline, and the diagnostics are inaccessible because of multiple reasons. One of those main reasons is that we have no big innovations coming, and at the same time, the current diagnostics are quite expensive for most of the countries. So before presenting you the solution, which has been developed by a team of scientists at Satyasai University in Andhra Pradesh, in collaboration with Scienvi and other organizations. I would like to very quickly take you through the problem. The problem is the empirical antibiotic therapy. And as most of you are aware, that because of this, we have most of the patients, coming to the healthcare institutions, either undertreated or overtreated, because our guess cannot be accurate, and clinicians cannot actually do a proper focused therapy unless they have got in their arsenal the diagnostic tests. Prior to me, I think the colleagues have really presented you with two very innovative and game-changing kind of products. And kudos to both of those companies and also to the researchers. In this case, I am not neither a researcher nor I own this company. I am just trying to bring the topic here so that more and more people would get to know what kind of innovations are happening in diagnostics front, especially in regard to the antimicrobial resistance. So these scientists, when they sat together, they looked at what is the current scenario as far as antimicrobial kind of diagnostics are concerned. They saw that most of these reports take a long time. There is a lack of scientific basis, and most of these diagnostics are quite expensive too. So when they looked at this challenge, they came out that, what should be the ideal kind of diagnostic tool or a diagnostic product they had to come out with. So they set the goal that, they had to have a kind of tool or diagnostic which is going to give instantaneous decision, which is going to be scalable, which is going to be cost effective. That was the kind of uh, objective they have set for themselves. And then they have gone through the comparison of various pathogen detection technologies. And again, as you can see from the slide, most of them are either time consuming, or they are expensive, or the pathogen detection capability is not really very high, or the scope is not very wide. That is the kind of thing. When you look at the impact of these emerging diagnostic techniques in comparison with the conventional microbiology techniques, as you can clearly see that the time again is something which is essence, and none of them are able to solve that particular problem unless clinicians are going to determine the most appropriate antibiotic in a clinically meaningful timeline. They would not be able to help their patients. That is the truth which you all know. And that is how then they have said that unless they are going to think out of the box and think about something where you are not going to have a very large setup, you would not be able to scale, and you would not be able to give an affordable product. And one of the ideas they have explored is to use artificial intelligence and also the machine learning in order to make a tool. I think, very aptly, Mr. Sriram has mentioned, the Molbio has gone to a route where they have made lab independent platform. And these guys, I think, have wanted to take a step further and ensuring that not only it is lab independent, but it is also highly scalable, where you would not need any equipment in the sense of having a kind of big box, or using any kind of consumables, etc., etc. So such tools are emerging. In this slide, you would say, 4 of those companies which had been compared, they have got varied levels of accuracy, levels of accessibility, varied levels of data security, privacy, scalability, integration, etc., etc. But again, this tool from India, which is called as AMRX, it is actually at the forefront of all of them in all the parameters which you can see from the slide. So what is this AMRX? It is a culture-free artificial intelligence and machine learning based companion diagnostic tool, which is probably going to be a big substitute over a period of time for the conventional diagnostics. And this particular tool is intended to reduce unwarranted, that is what is the word, clinical investigations, and its application will be useful, especially in resource limited settings. I would add to that, not only resource limited settings, but also even those settings where the resources are not a problem, but the personnel is problem in the primary and secondary settings. This clinical decision support tool can be very appropriate in order to reduce the empirical antibiotic prescriptions, and at the same time contribute towards the containment of global antimicrobial resistance problem. And as been said, this is instantaneous. This is highly scalable, very economical, compliant with the most of the regulations which are currently there for digital tools. And of course, this is a global South made, India made, India innovated kind of product. And I'm sure more such innovations are going to come into the vogue, come as the tools in the hands of the clinicians in order to very effectively address the rising tide of the problem. So I would not go on. I know that we are already out of time, so I would stop here and take if there are any questions. Thank you very much once again to GAMA for giving this opportunity.
Thank you very much, Dr. Reddy BURRI, for sharing about this AMRX tool, which is, as you said, culture-free, AI and ML-based companion diagnostic tool to reduce unwarranted clinical investigations, plus will help the people on the ground more for diagnostic purposes. Our next speaker is RITIKA TAKI, Director for Strategic Projects at DeepTek, another India-based initiative helping deploy artificial intelligence worldwide to find diseases early and accurately. Over to you, Ritika.
Thanks, Shobha. I hope I'm audible.
Yes, very audible, Ritika.
Thanks. So, thanks and good evening to everybody who are here today. Thanks to Bobby from CNS for giving us this opportunity to speak about our journey, and I'll be happy to share some insights that we have as a startup, and would be also happy to talk to the fellow innovators and fellow partners who are here on this call today. So my name is Ritika Taki. I'm the Director of Strategic Projects, and I'm representing DeepTek today. So we are a radiology AI company. So we were founded in 2017, and we are based out of India in a city called Pune. So we have 200 plus members spread across India and globally, where 115 are full-time members who are engineers and data scientists, and we have a huge team of radiologists who are on panel with us. So I think the start of the journey was with two co-founders that we have here, Dr. Amit Kharath, who's a radiologist by profession, and Ajit Patil, who's a tech entrepreneur. So I think two of them came together with a problem of having global shortage of radiologists. And Amit, being a radiologist himself, could feel the pain of radiologists where across the globe, not only developing countries, but also developed countries have huge shortage of radiologists, where imaging volumes are increasing year on year, and the burden on radiologists is also increasing. So that's where we came up with the company DeepTek. And along with the two of them, Amit being the domain expert and Ajit being the tech entrepreneur, we also have a strong leadership team and strong equity partners like Tata Capital Healthcare Fund and other Japanese companies who joined the league to build the products that we have today. So in terms of the market, obviously the medical imaging volumes increasing and the need of AI being felt, we could see a big market opportunity. But with the early adoption of AI, we could also see the challenges that are in terms of model decay or data drift, point solutions being difficult to adopt or difficult to have improvement in the productivity, and also how we can integrate these AI solutions into the existing workflows that the hospitals or the caregivers have. So that's where we came up with an end-to-end solution where we have two broad products called Genki, which is our chest X-ray AI solutions, and it's primarily used as a public health screening solution to screen the patients for tuberculosis using chest X-rays. But along with that, we also have Augmento as a platform, which is our AI deployment platform. And I'll talk about both of these products in a bit and keep it brief. But along with that, we also have a services component where how can we enable teleradiology services? And the aim of all these solutions together is to provide accessible healthcare and accessible radiologist services to the remotest part. So with these products, we were able to have around 500 hospitals and medical imaging centers, global presence in India, Singapore, Philippines, Thailand, and so on. we are currently doing around 150K scans per month on our platform. Being in India, we have access to affordable data to train our AI models. And also being research focused, we have 7 patents and over 30 papers in esteemed journals. Reaching to market is a difficult task for a startup, and that's where our strong partners help us in terms of getting reach to different areas and different countries in the globe. So one of the core challenges that any medical device or in healthcare ecosystem that you would face is the regulatory approvals, because for adoption and for your healthcare products to actually reach into the market, these validations are very important. And that's where I think a key tip would be, as soon as you get the money, whether it's through any funding agencies or through the Trinity Challenge, invest into regulatory approvals, because that's very important. As a startup, we realized into your journey to get your products adopted and from going from pilot phase, reaching to a phase where these solutions are reaching to the markets and getting adopted in a very safe manner. So what do we actually do in terms of what our AI does? So tuberculosis is a big problem, and so many of my colleagues have already spoken about it. So we have a chest X-ray AI solution that would help us triage tuberculosis patients, reducing the burden on the confirmatory test. That could be a sputum test, which could be expensive. So WHO has also recommended use of chest X-rays as a screening tool. And what our AI does is uses a chest X-ray and identifies if it's a TB suspect within a minute. Our solution is surpasses the WHO TPP guideline of 90% sensitivity and 70% specificity. And we also have regulatory approvals with which we are able to deliver the solutions to various countries. Along with Genki, which is an offline solutions which can work in a remotest part without internet, we also have Augmento as a platform, which will help us connect not only the communities, but also existing infrastructure in terms of the primary healthcare centers who have modalities, being X-ray machines or CT or MRI machines, and sending the images through a gateway to a centralized solution where any radiologist or expert sitting from anywhere can access the scans and can basically give you a detailed report very quickly. Apart from that, we also have a mechanism to integrate other third-party AI models into the platform so that the healthcare givers can use those models in a very seamless manner. And we can also provide national dashboards. We can integrate with existing national dashboards and give you a centralized view of all the programs that are running. So summarizing, the solution is primarily used for tuberculosis, but is also used by imaging centers for their daily radiology needs. So as I mentioned, I think one of the key reasons why we could reach to market is the regulatory approvals that we have here. So I think one of the most stringent approvals in terms of US FDA, we have the US FDA approvals for the solutions. For India level CDSCO, again, our primary focus earlier was on the South Asian markets because most of the TB specific countries, TB burden countries are in this part, but now we are also moving to Africa and have also we have CE approvals also in pipe. So basically expanding our reach to different countries now. So talking about our implementations and keeping it short, we have major implementations in India where we have implemented all the solutions and making it an end-to-end solution and screened over 500K people. And with this, we have seen 25 times increase in the yield of identification of TB suspects. So such solutions are also implemented in different areas, especially with ultra portable machines. So now these machines have the capacity and the mobility to reach to the remotest part. And with this, we are in over 100 sites in India. And we have also implemented in countries like Mongolia and Philippines, where we are helping the government bodies or NGOs in tuberculosis screening. Few of the national deployments that we have targeted to actually get healthcare accessible to countries like Bhutan, where there are only 8 radiologists in the entire country, is integrating Augmento with their national EPIS system so that radiologists sitting at the national referral hospitals can even access a scan coming from basic health unit and can give a report so that the patient doesn't have to travel for 2 days and reach these hospitals because of the difficult geographical condition and terrain that they have. Apart from that, one of the flagship project is in terms of Singapore, where we have integrated AI marketplace and the existing RISPAC system through Augmento, being the orchestration engine, where any radiologist sitting in any of the public health hospitals that we have implemented in can use AI with the click of a button and can choose which AI partner they want to use and can enable it in their reporting mechanism. With this, we have also written a paper and seen almost 91.73% reduction in turnaround time and 73% reduction in the report generation time. And this is a massive improvement in the workflow integration with the use of AI and with the use of the technology that we are providing. So just to summarize, I think the startup journey is a difficult one with ups and downs. So for us, it started with the incorporation and funding, which played an important role. And I think that's where the Trinity Challenge would really help startup in early phase to basically get the right resources, to have pilots, to have correct amount of implementations, and to get your regulatory approvals so that you can reach the market. So that has been our aim, and we, as an organization, would really want to be the most valued health tech firm, and we continue on this journey. So thanks everybody for listening, and if there are any questions, I'll be happy to take. So have a nice day.
Thank you, RITIKA, for sharing an overview of Genki and your Augmento platform with our audience. Now, last but not the least, I invite MADHUSUDAN KAPHLE, a young entrepreneur who leads Nymat, Nepal as its founding executive director. He has successfully engaged a growing youth movement in TB and AMR responses. Over to you, MADHUSUDAN.
Thank you so much, Shobha ma'am. Am I audible, ma'am?
Yes, you're very audible. Yes.
Okay, thank you. Namaste, everyone. My name is MADHUSUDAN KAPHLE, and I'm the founder and executive director of Nymat. It's a youth-led organization working in Nepal and beyond. It's an honor to be here today to talk about our recent Youth Against AMR campaign and how young people are stepping up as leaders in the fight against antimicrobial resistance and tackling one of its root causes, the problem of substandard medicine in Nepal. We believe that young people are not just the future, they are powerful agents of change today. That's why we launched the Youth Against AMR campaign to support National Action Plan of Nepal government with the support from WHO Country Office Nepal. So the campaign has had 5 levels: no AMR, the first level, unite against AMR, fight AMR, innovate and get reward, and lead for future. So we wanted to engage more than 1,000 young people at that time, but we received almost 3,000. So we decided to enroll everyone in this particular campaign, covering all province of Nepal throughout the country. In the first level, there was hybrid training, especially designed for our young people who were like undergraduate medical student, public health student, and recent graduates. So on that particular level, we provided them online courses and virtual expert session. Once they completed that particular level, there was another level, Unite Against AMR. We wanted to make them understand that being unite is very important in this fight against antimicrobial resistance. So we encouraged them to establish National Youth Coalition Against AMR and youth clubs and networks in their own institution and provinces. After that, Fight AMR, they are doing really good activities, wonderful activities in the community. They are doing a family conversation, school health program, educating the future generation. They are doing community-based advocacies, reaching local governments, leaders, and stakeholders. Another label, innovate and get reward. We are encouraging our participants to design their own intervention, innovative ideas, so that we can support the implementation and promote like sustainable activities through their own established network, and then lead for future. Now they will run this all these clubs, networks, and a national coalition by themselves. So that was the overview of this our recent campaign. Through this initiative, we have established, I already mentioned this, National Youth Coalition Against AMR, which connects all the 31 youth networks, engaging over 2,500 young people, including medical doctors and public health professionals. We have just reached more than 20,000 people directly in last 2 weeks with critical education on antimicrobial resistance, along with a Global South Youth Network together with young people of the region. So substandard medicines are a clear and present danger. They just they don't just fail to treat illness, they actively contribute to the rise of antimicrobial resistance. So this isn't just a health issue. It's a huge threat to our very fabric of our communities. So in Nepal, we face a unique challenge, our open border with India. So it makes challenge for both countries. So it's very difficult for both countries to regulate such substandard medical products. So we, through our network and young participants and members, we are addressing those issues also, the cross-border issue of substandard medicines. We are conducting a school health program, community-based advocacy and awareness, and we are doing partnership with local governments and stakeholders. And building a generation of informed and passionate advocates. We are also running a innovative training campaign to equip young people with the skills they need to make a difference and stepping up to address this issue. So the evidence is clear that substandard medicines are a massive problem and we must take action. That's why we are advocating for a stronger regulation and greater cross-border collaboration with India. We are also proud to support initiative like the Trinity Challenge, which focuses on improving access to quality antibiotics. So at the heart of all of this is a simple truth. When we empower young people, we are not just solving today's problem, we are building a healthier, more resilient future for everyone. So I would like to stop here, but I'm very happy to address any question or you can share any thoughts regarding this, and looking forward to participate in more discussion in future and sharing more about findings of our work. Thank you so much. Over to you, Shobha ma'am.
Thank you very much. Thank you, Madhusudan, for sharing the youth response to controlling AMR in Nepal. You are doing great work there. Now, with this, we come to the close of today's session. We have already overshot the time. I do not know by how many more minutes. Friends, COVID-19 pandemic has shown us that it is only the public or government-run services that were functional during that time, no matter of what level they were. We have to ensure we keep people before profits. Public health services are critical, and access to public health and social services with equity, rights, and justice is even more critical. Let us hope that innovation is spurred for health justice and is protected from corporate capture. We stay united with you all for development justice for all, where truly no one is ever left behind. Thank you very much for being there with us today, and all power and force to all the innovators working for the cause of public interest. Thank you very much.